My name is Mike Postelnik. I'm the program director for antimicrobial stewardship at Northwestern Medicine. I'm so happy we're back in person with the Stewardship Summit. I've been coming to these since they started, and they're always really very valuable, and it's great to see everybody here. So I have the privilege of introducing Dr. Mohammed Dhanani. He's the newest physician member of our antimicrobial stewardship team in Northwestern. Dr. Dhanani, he's an assistant professor at Northwestern University Feinberg School of Medicine. He completed his residency and fellowship at Boston Medical Center. He also completed a fellowship in health professional education between finishing his residency and clinical training. Dr. Dhanani comes to us with a great deal of interest in antimicrobial stewardship. He's been a tremendous asset to our team. And in the past year, he's been working very hard on outpatient antimicrobial stewardship. He's going to talk to us today about methodologies and measures for tracking antibiotic use in outpatient settings.
Thank you, Mike. So yeah, it's my pleasure to be here and talk a little bit about this topic. I'll just open by saying I have no relevant disclosures today. An outline, so I'm going to first try to talk a little bit about why measuring is important, and then talk about how it's confusing, and then some thoughts on going about choosing a metric, and I'll close with some additional considerations. So why is measuring important? I'm sure you've heard this a ton of times today, but it's a required activity. So as we all know, the CDC core elements of outpatient antimicrobial stewardship contain an element called tracking and reporting, and that helps inform Joint Commission standards. And there are also payer incentives that would incentivize us to pay attention to our data. Measurement's also important because it provides guidance on strategic planning for our stewardship interventions. It helps us understand which interventions are effective and how effective are they? Are they worth continuing? Should we try a different strategy? Questions like that. And I think it's also important to measure to ensure equity. So we want to track clinical outcomes in vulnerable groups and mitigate the risk of harm that we might, unintentionally incur on vulnerable populations, and also identify areas for improvement in the care of those vulnerable groups. So how it's confusing. And so I have a confusing example here. This is thanks to Dr. Linder here. So you're the stewardship champion at your facility, and you're just getting started, and you kind of want to get a sense of prescribing behavior. And so you're particularly interested in respiratory tract infections. So you pick out a couple diagnoses, you pick out the particular ICD-10 codes to go along with them, and you decide to focus on some non-antibiotic appropriate diagnoses code groups and some antibiotic appropriate diagnosis code groups. So your initial data shows that about 60% of patients got antibiotics for the non-antibiotic appropriate diagnosis groups, and about 60% got them for the antibiotic appropriate diagnosis groups. So overall, about 60%, right? So maybe you were expecting, a little bit less antibiotic use in the non-appropriate category, but what you found was everything was the same. So you do your intervention, and you go back and you look afterwards, how are things going? And you find out that, among the non-antibiotic appropriate diagnosis groups, your rate went up, right? 60% to 80%. That doesn't make you maybe the most convinced your intervention went the way you wanted it to go. And you notice that among the antibiotic appropriate diagnosis groups, your antibiotic prescription went down. But I think when you take a closer look, you see that the raw numbers for these specific ICD-10 codes went down in the non-antibiotic appropriate groups and went up in the antibiotic appropriate groups. So your coding shifted, right? And so that's why you have to pay attention and design your metric to be sensitive to some of these coding shifts while also giving you the percentage data that you want to take away. So this is, I think, a nice example of why we need to design metrics that work for us. Metrics need to be resilient to clinicians' behavioral changes, such as diagnosis shifting, as I mentioned, and seasonality is another one that we see in the outpatient setting a lot. Metrics need to be clear in their strengths and their limitations. Ideally, they're straightforward to calculate from EHR data, right? You shouldn't have to do a lot of processing to come up with these. And I think when you're doing that stewardship outreach, talking to other stakeholders, using metrics that are straightforward to understand is your friend. So choosing your metric. So I'm going to go through a number of metrics, but first some overview. So different metrics derive from different data types and have different uses. Metric selection can be dictated at a given facility by the available IT resources. You know, if your software functions a certain way, you might find it easier to tag certain metrics over others. I think in the inpatient side, this is very tangible, right? That metrics closer to the patient may be more accurate. So you think about a hospital, the prescriber orders a medication, say meropenem, and it goes through the pharmacy, it's verified, and then it gets administered by the nurse, and the nurse checks it off in the the MAR. And so it's very clear whether a medication that was prescribed and then dispensed was taken by the patient. And that's not true in the outpatient setting. It's a lot messier. So there's a risk of overestimation in the outpatient setting. Patients don't always take their medication that is prescribed or, complete the prescription or take it the right way. So, you just know what has been dispensed or prescribed. You don't know how the patient's actually taking it, unless it's part of a study or some other format like that. And then there's a risk of underestimation, right? So patients receive samples in the office. That's not captured by insurance claims data. Patients purchase antibiotics over the counter overseas. Not every country has prescription requirements for antibiotics, and so patients might come home from a trip abroad with them. Patients may pay out of pocket for medications, and that may make a metric that uses insurance claims data underestimate that patient's antibiotic utilization. So some flaws there that you don't really see on the inpatient side. I think another key point is that metrics kind of rely on diagnostic accuracy and billing accuracy. And I think that's one thing that was maybe just mentioned. So providers may not make the kind of true diagnosis. I think those of us kind of on the diagnostic side, we, I think, understand better than the metrics can tell that diagnosis is not always as clear cut as the code might lead you to believe. And providers may not select the kind of true ICD-10 code on which your algorithm relies. We know that ICD-10 codes are very specific and that you have to make sure you capture them the right way when you're designing your report to build your metric. I think the other thing to note is that, as I mentioned, metrics come from different sources. So you have purchasing data. This is like wholesale order data that is placed to suppliers. And so it's orders placed by hospitals, post-acute facilities, clinics, and retail pharmacies, and that gives you one insight. Then there's prescribing data, which is data from the EHR or from retail pharmacies or post-acute facilities, insurance claims. It tells you how prescribers are behaving. And then there's dispensing data. This is data from retail pharmacies, outpatient post-acute facilities, home infusion pharmacies. So each one of these sources gives you a different slice of data. So when I think about metrics, I think about them as in a couple ways. So there are population or group metrics that measure use per 1,000 inhabitants per day, and we've seen a lot of different depictions of this. There's prescriber metrics, and here I also think about measuring duration, measuring appropriateness, and measuring rate or amount of prescribing. So a couple different ways to think about them in broad strokes. And now I'm going to go through a bunch of metrics. It gets a little dry, I'm just warning you, but hopefully still relevant. So measuring use per 1,000 inhabitants per day. So this is the DID, as it's called. So what is the DID? Well, it's the DDD per 1,000. So the DDD, an endorsed by WHO metric, that's international standards for inpatient and outpatient use. And the DDD is based on the average maintenance dose for the main indication of the drug in adults. It converts an amount that is prescribed in grams or milligrams to a fraction of that drug-specific DDD, and it can be calculated from purchasing or dispensing data. And so that's the formula. I think some strengths useful for comparisons across space, time, and geographic settings. It's not affected by variation in cost, in pack size, in course duration, or the prescribed dose. But there are weaknesses here, and the weaknesses arise in use outside the indication or the population used to define the DDD, right? So we know it was defined by the WHO as in a very specific way. And so if we use it outside that population, it doesn't hold up as strongly. And so just a tangible example. So, the DDD for levofloxacin is 500 milligrams per day. But if you have a patient with kidney disease that is severe enough that merits a change in the frequency, the DDD is not going to recognize that. And it's also going to be insensitive to weight-based dosing, as we use in pediatrics, and thrown off by other dose changes, like perhaps increases. I mean, I just talked about decreases with kidney disease, but increases like we might use in osteomyelitis treatment for sulfamethoxazole trimethoprim. So I just want to introduce, I thought an example might help as we go through the various metrics. So hypothetical medical group, so is our clinic. It's a concierge practice with 10 providers and on-site pharmacy, which is only used by our 2,000 patients. You're the stewardship champion. You want to decrease levofloxacin utilization for patients who have an ICD-10 visit code that matches to UTI. So you're kind of looking at, okay, what's our current status? So we wrote 100 prescriptions for levofloxacin 500 milligrams over 3 days for patients with UTIs. As I mentioned, the DDD for levofloxacin is 500 milligrams. So how are we going to calculate our DDD here? So 100 scripts, 500 milligrams, 3 tablets each. So 150,000 milligrams or 300 DDDs over a 3-day period. So maybe 100. So, but how, I think, if you noticed that the DID is corrected per 1,000 population. So how do we know how many people make up our base population? Is it the number of patients seen in a clinic today? Is it over 3 days? Is it something else? So I think this is not really, this is a nice metric for some purposes, but I don't know that it's the best metric for the purposes that we are trying to use it in our current work in our ICU, immediate care centers at Northwestern. So I think that a DID used by a practice may be difficult. It's nice when you have a tangible boundary or a clear at-risk population. And so it's nice to use in maybe public health or inpatients in a large hospital system. This is one example. This is a map of the US. It uses a population corrected metric to look at number of antibiotic prescriptions given to per 1,000 patients in a given state. And you can see here the state-to-state variation. This is based on a IQVIA database. So this is, I think, a nice use of a population corrected metric. DOTID is a related metric that focuses more on days of therapy per 1,000 inhabitants per day. DOT, I think, days of therapy itself is an important metric, but kind of doesn't have that population correction. DOTID is defined as number of days prescribed per 1,000 population, and in a sense, therefore, it's more accurate than DID because it brings in that duration. So it can be used to assess prescribing changes around broad-scale public health interventions, and it can be calculated from purchasing or dispensing data, and that's the formula. But I don't want to spend too much time there. I think the kind of more helpful metrics at the clinic level are things like APR. So not your credit card, antibiotic prescribing rate, can be calculated from prescribing or dispensing data. The numerator is the number of antibiotic prescriptions written, and the denominator can vary. So you can use the population or subpopulation of an area, and that will allow you to capture multiple prescribers, maybe even if not affiliated to each other. You can do a kind of crude assessment, looking at the denominator as a number of patient visits, and then you can do a more refined assessment, looking at the number of patient years. And I have some trouble thinking in patient years, so I like number of patient visits when we're doing some of this work ourselves. It can be useful to compare prescribers to each other or the impact of an intervention, evaluate the impact of an intervention. So the formulas for that would be, if you're using prescribing data, then you're looking at prescriptions written. If you're looking at dispensing data, then you're looking at prescriptions dispensed. So APR is, I think, more clinically relevant than the previous metrics, but like the previous ones, it'll be blind to the accuracy of diagnosis and the code selection. So it has a weakness as well in that it doesn't tell you anything about appropriateness. You know, the agent selection, dose, and duration. You don't get a sense of whether they're appropriate either at a patient or a cohort level. So if we go back to our hypothetical medical group, and we think about the fact that we wrote 100 prescriptions for levofloxacin for 500 milligrams for 3 days, what do we need to calculate our APR? And this is specifically looking at visits where UTI codes were used for billing purposes, because you're looking at UTIs. So how many patients were seen today? And the other thing I think to think about is, was each antibiotic prescription of levofloxacin given to a unique person? So was it a situation where maybe you had a patient come in and the provider gave them 3 prescriptions just in case the first one didn't work, then you take the second one, and then if you still have symptoms, the third one. So we looked at that and we saw 200 patients total, and each prescription went to a unique person. So if we had 100 prescriptions written to 200 patients who had UTIs in our medical group today, then our APR will be 0.5. But I think it's useful because you can also give you a window into variation within the prescribers. So we can rank the prescribers by their individual metric for this drug. So if you think about, maybe one prescriber gave a prescription to every patient today who came in with UTI as a diagnosis code for the visit, and then another prescriber gave levofloxacin for only 10% of those patients. You just make sure that the denominator captures how many individual UTI patients were seen by that provider. And then you can calculate each provider's APR. And you can look at it another way. You can leave UTI and you can say, I'm going to look at the APR for the drug based on the syndrome. So you can look at the prescriber's APR if for sinusitis prescription, for UTI prescription, and you can kind of use the ICD-10 code grouping as your distinguishing factor. And what this allows you to do is develop a basis for fair comparisons and also measure the impact of the stewardship team's activity. So proportion of antibiotic prescriptions can be calculated from prescribing or dispensing data as well. It's a similar numerator, so number of antibiotic prescriptions written, but the denominator is a number of total prescriptions. So this one would acknowledge some prescribers are generally more likely to prescribe anything compared to other prescribers. And this can also be used to compare prescribers to each other. This is the formula here, antibiotic prescriptions over total prescriptions. It can be relevant for clinicians, but it's got some weaknesses because that behavior likelihood to prescribe in general kind of goes along with likelihood to prescribe antibiotics, arguably. Maybe it's not going to give you a lot of new information. So just to go through this same metric with the hypothetical situation. So the information that you need that is new is how many prescriptions were written today. And so if your providers wrote 100 scripts for levofloxacin to UTI patients, and they ordered a total of 300 prescriptions for UTI in general, then that gives you this metric at 0.33. And again, you can rank the prescribers, but it will account for the general likelihood of ordering any drug. This metric would allow you to look at duration. It's kind of a twist on the last one. So you fix your numerator so that you pick a duration of time. And if you want to look at prescriptions more than 2 weeks, then your data point only gets in the numerator if it meets or exceeds 2 weeks, but your denominator remains all prescriptions. So then you have an easier time identifying prescribers who don't prescribe antibiotics particularly more commonly, but who do prescribe excessively long durations. And we know that a lot of stewardship interventions can be focused on addressing duration of therapy. This is useful for that. And then we come to appropriateness. And I think appropriateness is a great word in that it captures a lot of things about what we do with stewardship. This is a very clinically relevant metric. It measures concordance with pre-existing guidelines or some other gold standard. It can incorporate elements such as, yes or no, was a prescription written, but it can also capture how appropriate was the agent, how appropriate was the dose or the duration. And again, it does kind of presume an accuracy of the underlying diagnosis, but it adds a focus on quality. The drawback is that it requires detailed chart review and that it doesn't translate well between settings. So you could have different settings have different gold standards. You have nuance related to antibiograms, facility formularies, insurance carrier formularies. And so maybe it doesn't translate super well between settings that might differ a lot from each other, but it really gives you a nice window into the quality of your prescribing behavior. So I think another strength about this metric is that you can shift your framework from dichotomous to ranked. So it's not so much a yes/no in appropriateness, it can be a ranked kind of understanding. So you can say things are like optimally appropriate, they're completely aligned with guidelines. You can say they're adequate, so maybe a reasonable decision to prescribe, mostly guideline concordant, maybe some things to tweak around the edges. Suboptimal, where again, it's a reasonable decision to prescribe, but maybe some more room for improvement. Inappropriate, where you have an antibiotic that's prescribed that's not effective or not recommended for the specific reason the patient was prescribed an antibiotic. Or unnecessary completely, where you had a patient with a non-infectious process or at least a non-bacterial process who was prescribed antibiotics. So this, I think, is nicely articulated by the AHRQ toolkit. Here where they mention a number of syndromes that are upper respiratory and lower respiratory syndromes, and you have ICD-10 codes that kind of guide you about building your report. And then you see how the AHRQ conceives of these syndromes in terms of how much antibiotics are merited for them. And this kind of gives you that ordinal perspective that I was mentioning. So just to go back one final time to our hypothetical situation. So if today we wrote 100 prescriptions for levofloxacin for 500 milligrams, all for 3 days, to think about appropriateness, we need to look at patient charts and consider syndrome-specific guidelines. So think about it, each patient, was that dose of 500 the right dose? Was levofloxacin a supported drug for the suspected infection? So was there prior microbiology? Do we want to be using quinolones for this infection? And was 3 days the supported duration? So were some of these patients managed? We have not picked 3 days and maybe a different duration. So this approach is obviously more labor intensive, but it does help us identify outlier prescribers and infectious syndromes needing our stewardship focus. But it does require a lot of chart review. So there's another way to look at this, which maybe allows you to dodge some of the chart review and add a benchmarking capability, estimated appropriate APRs. And using a diagnosis or syndrome specific APR as the target. And I think this is where using literature can be helpful, and then understanding what the target should be for the patients you're looking at in terms of how much percentage of the time they get an antibiotic prescribed. And this can be used to compare individual prescribers or collections of prescribers. Okay, so that's a lot of metrics. It's a lot of abbreviations. So metrics require different input. They require a variable amount of work to get source data, and they convey different information. So I think the key is to find ones that are meaningful to your program or your efforts for the various things you do, like tracking and reporting, assessing impact of interventions, and thinking that maybe you might need multiple metrics, and just keeping in mind that you narrow subpopulations appropriately, i.e. in the numerator and the denominator, in the way that makes sense for your metric. So more broadly, so we think about our behavior and stewardship along this continuum of observation, data, and then action. And so how to build metrics into that. So if you start off by picking a low-hanging fruit, like a common diagnosis where antibiotics are infrequently needed but often prescribed, and then you move on to the next step, which is to understand why this diagnosis is prone to overtreatment, then I think you can recall the estimated appropriate APR and use literature to articulate the recommended rate of treatment and help build what kind of metric you're shooting to design and where your benchmark should be. And then you choose and measure the metric in a way that makes sense with your IT infrastructure. And as you understand the behavior, you also can identify the gap in your facility. And you can spread awareness among your providers about treatment guidelines or your gold standard, and also raise awareness about why people are over-treating or maybe not optimally treating. And then you want to follow that same metric over time to understand the impact of your work. So if we just take an example of sinusitis, so if you're the champion and you observe that we overtreat sinusitis in our clinics, that's your observation, and that's a low-hanging fruit because it's a common diagnosis. Antibiotics are infrequently needed. The IDSA says 2 to 10% of the time, and often prescribed, and often actually prescribed for longer than they should be. So understanding why this diagnosis is prone to overtreatment, right? So there are some myths, like discolored mucus means that the infection is a bacterial infection. And there are some truths that people with sinusitis are going to be miserable, regardless of whether it's bacterial or viral. And that people often get 2 weeks of antibiotics when 1 week will do the trick. Step 3 would be to identify literature articulating the recommended rate of treatment. So I just mentioned the IDSA guideline from 2012 states that 90 to 98% of acute sinusitis is viral, or inverse 2 to 10% is bacterial. So then choosing and measuring a metric that makes sense and is easy to obtain from IT. So I think a nice metric here is a sinusitis-specific APR. So it allows you to look at individual prescribers and the clinic overall. And so you make sure that your numerator is only both actually your numerator and the denominator is only patients with sinusitis. And that's why using ICD-10 codes can be a good strategy here. And you also want to look at duration. And there, I think you use the same approach, but perhaps you use the metric where you have the cutoff in the numerator of prescriptions that are exceeding 7 days in duration. Then you identify the gap in your facility and spread awareness about treatment guidelines and why overtreatment occurs. So this is where you have an opportunity to have a campaign in your facility. And you can do a lot of education about sinusitis. You can inform prescribers about their individual level metrics at the baseline data, and you can create guideline documents. And so just a plug for adsbs.nm.org, which is our public website of our stewardship program at Northwestern. It has a lot of resources, but most recently we have gone live with some one-page documents kind of tailored to the outpatient setting, tailored towards our antibiogram as well, but it's a lot of good information, and we have a couple different outpatient conditions with a very succinct description of symptoms, how to make the diagnosis, testing, and management, as well as non-antibiotic management. So that's just the top of that one-page document. And then the last step would be to follow the same metric longitudinally. Perhaps you want to get back to your prescribers at the end of the intervention to see, who really had a nice change in their prescribing behavior. So in terms of prescriber level metrics, which I just mentioned, this can be tricky. It can require a careful navigation of interpersonal interactions. You may be recommending changes in behavior to somebody who is quite your senior, But I think it's an important thing to focus on, that this is all to improve patient care. For individual prescribers, in the senescence example, I mentioned the metrics already that I thought might make sense, like the senescence specific APR and then a different approach to measure duration. But in terms of follow-up action, identifying outlier prescribers can be helpful for one-on-one academic detailing, where you kind of can go over cases and talk about agents that were selected or durations that maybe were not aligned with best practices. You can reinforce throughout the facility with widespread education about key messages. You can provide feedback longitudinally using data from ongoing measurement. So this is like where a dashboard that providers can access in real time can be helpful. And of course, you want to celebrate improvement. You want to provide positive feedback. Okay, and just to switch tacks for a second to some additional considerations. So I think we talk a lot about metrics, but do metrics tell the whole story? And I think that that's a valid question. So we are seeing discussions on how drug spectrum measurement can be integrated into metric development. So recall days of therapy, right? So this is the WHO defined DDD of a given agent, with each day counted as a unit. So if you gave 2 days of 1 DDD of linezolid and 1 DDD of meropenem, that would be the same as giving 1 day, 1 DDD of ceftriaxone and 1 DDD of metronidazole, right? Even though the spectra are wildly different. So meropenem actually by itself would be a value of 1, whereas ceftriaxone and metronidazole will be a value of 2. So this can create an incentive, if you're looking at this metric, to use a single broader agent rather than 2 narrower drugs. So we need to think about how to incorporate agent spectrum, because that's actually how clinicians think, right? We think about spectra. And so I just want to mention that there are some ways to score spectrum. So many of you might be familiar with the WHO classification, that this is not a metric in and of itself, but it's a kind of ordinal way of looking at antibiotics, where they classify antibiotics into access, watch, and reserve, and really try to encourage people to use the access and not so much the reserve. And then there are other systems that assign numerical values to antimicrobial spectra. And this can help quantify stewardship interventions, as well as quantify decisions to escalate and de-escalate. And there are many examples here. I've listed a couple. But I think it's important to mention that they've done studies where they've seen stewardship interventions are tangible in the difference they cause among these metrics or these scores, but not tangible among the metrics I discussed earlier. So it shows you that maybe for our stewardship work, we should use things that are more like this because we want to capture our work effectively and understand our impact. But I think in general, this is still an area under development, but I think it does raise the clinical relevance of metrics if we were to add spectrum into our metrics more routinely. Okay, and so these are just, I think, some key resources for this kind of information. I have some acknowledgements. I definitely want to thank Dr. Linder, and as well as everybody at this table, including Dr. Postelnik here. And so I'll take any questions. Yeah. Yeah.
What do you recommend if you don't have an electronic health record that will spit all this out for you?
Yeah, that's a great point. I wonder whether insurance claims or retail pharmacy might be a source of data. Yeah, that's challenging, definitely.
And that's most of rural Illinois.
Yeah. I think the pharmacy hopefully can be a way to do it. Yeah.
With outpatient antibiotic prescription, I mean, the biggest thing I see partially is like the urgent cares.
Yeah.
Are the one, Walgreens, which is in business to sell medicine. And I mean, you always see those people come back after they visit the nurse practitioner, like they're not to be bad, but it's like, wow, they just like get handed out like candy still.
Yeah, no, we have a lot of work to do. I definitely agree with you. Yeah.
But there's also a dynamic, if you go to the urgent cares and ask them, they're like, it's the primary care doctors.
yeah,
And then if
yeah.
you go to the primary care doctors, they're like, it's the retail clinics, and
Yeah.
everybody's pointing their fingers at
Yeah.
everybody else.
Yeah.
And-
But at least at the ones that primary care doctors usually have some lab backup.
Yeah.
I mean, but if you go to the urgent cares, they don't have any lab backup, correct? I mean, it's.
Yeah, I think, we've worked a lot with urgent cares at Northwestern, and I think we've had a positive experience. And I think it's also about building relationships and kind of meeting people where they are.
Well,
as well.
especially too,
Yeah.
them all being run by like retail pharmacies. I mean, they want to be sell medication.
Yeah.
So I mean, you're fighting against
Yeah. Hi, yeah.
So what's your advice? We've been publishing acute sinusitis, upper respiratory and viral infection and their antibiotic prescribing habits, and we are blasting everyone's name. They're changing their diagnoses. So how do I chase that?
Yeah. What do you think?
So that's actually, part of the answer is the diagram you
Yeah.
showed about diagnosis shifting.
Yeah.
So you have to, make the balloon a little bit bigger, right? So
Okay.
that you squeeze part of the balloon and it's pooched out.
Right,
You actually have
but
to-
how do I track what they're using instead? So that's my, it was like, I have my ICD-10 codes for
So-
these.
So what we actually have a dashboard at Northwestern where we track the clearly inappropriate antibiotic prescribing, right? So antibiotics for colds, flu, acute bronchitis, where the right antibiotic prescribing is 0.
Okay,
Then we have a broader basket of diagnoses that we call sort of our, and there's some like bad behavior diagnoses like cough, fever,
Yes.
like you would
Yeah.
never,
yeah,
Yeah.
cough is the
where, and we actually call that our diagnosis shifting category. And then you actually want to get around all antibiotic prescribing at some point too.
Right.
So, that's the ultimate goal, right? If you just, as we say, like if you're focused on acute bronchitis with the HEDIS measure from 7 years ago, and you eliminate the diagnosis of acute bronchitis, but overall antibiotic prescribing doesn't change, like that is not victory.
Yeah.
And so you actually need to look,
Okay.
broader. So usually it's like a specific thing you're targeting, shifting measures, and then ideally like all, I feel like the things have moved in like HEDIS measures and like the work we're doing to like get your hands on all outpatient antibiotics.
Okay. All right. Thank you.
Thank you.
All right.